I'll hand it over now to my colleague, Dr. Abdulaziz Ashkanani. Dr. Abdulaziz is a consultant neurologist and he is a consultant at Al Ahmadi Hospital. And he's a neurophysiologist and the president of the Kuwaiti Chapter International League Against Epilepsy. Dr. Abdulaziz, he will moderate our one of the excellent session, which is a neuroradiology with our best neuroradiologist, Dr. Lamia Sarraf and Dr. Khalid Jad. I think without neuroradiologists, we are maybe useless in neurologists. So I'll hand it over to Dr. Abdulaziz Ashkanani.
Thank you, Dr. Jassim. And for the last session of the day, the neuroradiology, which is, I think, put in intentionally at the end of the day to keep people waiting to see the images and excellent radiology that we need to every day. Our first speaker is Dr. Khalid Gad. He's a consultant neuroradiologist at Ibn Sina Hospital in Kuwait and assistant professor at the Faculty of Medicine of Suez Canal University in Egypt. Dr. Gad has received 2 training fellowships at Johns Hopkins Neuroradiology and at Virginia Tech Neuroscience and Functional Neuroimaging Lab. He has a special interest in education. In 2012, he obtained a master's degree in health profession education from Maastricht, the Netherlands. He's affiliated to the University College of London, where he's finishing a specialized master's degree in advanced neuroimaging from the Queen's Square Institute of Neurology. Dr. Gad's research interest is becoming more focused on advanced neuroimaging techniques in neuro-oncology. He serves the American Society of Neuroradiology as a member of its educational committee and reviewer for the AJNR. He's joining us today from the UK to talk to us about how to read the brain MRI, and he's going to take us in a tour from gray shades to color maps. Dr. Gad.
Well, thank you, Dr. Ashkanani. Thank you also, Dr. Jassim, for the invitation. So my target audience is actually the junior staff, trainees, and other beginners. And the title of my talk is actually very challenging. I'm not sure how can I cover all brain categories of lesions in only 25 minutes. So I'd rather refine my talk title into a tour from gray shades to color map. So I'll be more than happy to take you through a tour into a brain gallery, if you will. And like with every other, with all tours, we're supposed to start by giving a short orientation of what you should expect to find or to see in the tour. So we'll start by seeing a white gallery, and then we'll see a black gallery, because all MR images of the brain are just a mixture of black and white things. So and these galleries, under these galleries, we'll see a bad exhibit and a good exhibit. Good means normal and bad means abnormal, and we'll be seeing both exhibits in a white gallery and black gallery. And before the end of my tour, I'll make sure to stop at the color zone, the color section of the tour, where you'll be able to see some fancy and beautiful images, colorful images that neuroradiologists can provide to the medical community and the scientific community as a whole for better interpretation of findings. Are you ready to start the tour now? Okay, so let's start by this gallery. So the first gallery is when white is good. The white is good in MRI in there are a couple of structures which are normal and good when you see in MRI. This includes fluid, as in T2, CSF clear fluid is bright and white, and also fat is white on T1 and on fast spin echo T2. Both arteries and veins are white. Expect to see that in MRA and MRV respectively. And normal enhancing structures of the brain will be, of course, white because of gadolinium. I'm not going to cover any gadolinium patterns of enhancement today for the sake of time. So let's see this example of a normal MRI of the brain, T2 coronal and axial, and see the ventricles here. The fluid inside the ventricles is white. This is good. And the fluid in the sulci is also white, and also around in the basal cisterns here. Look also at the fat in the scalp. it's white. So keep in mind that gray matter is brighter than white matter on T2, and this relation inverses in T1. And again, fat appears bright or intermediate in T2. So when you lose this normal, this good stuff, when you lose the white normal thing here, you have an increased intracranial pressure. There's effacement of ventricular system and effacement of the salt fluid, as you can see in these cases. Other features of increased ICP include optic nerve sheath prominence, brain herniation, and loss of gray-white matter differentiation. Another example of a good white stuff is flow-related enhancement in MRA. So I said flow-related because it's not enhancement, it's just flow-related. So all this is just because of flow. And you have a normal ICA here, and you lose the good thing here on the right side because there's total occlusion of right ICA in time of flight MRA. Remember that we have three basic techniques to do MRA in neuroimaging. Two of them require contrast administration. Two of them does not require contrast administration, time of flight and phase contrast, and the third one apparently requires contrast administration. Another example of MRA, when you lose the normal white internal vasculature beyond the terminal ICAs in a case of brain death. So when you see something like that, it's the most reliable sign to make a diagnosis of brain death, and the gold standard is actually DSA, not MRA. Another example of a normal white thing that you lose here with this focal stenosis on MRV of bilateral transverse sinuses in the terminal parts. And you can see it also here in a patient with idiopathic intracranial hypertension, that this focal stenosis of transverse sinus is the best single imaging finding that can predict IIH. Now, we're still in the white gallery, but now we're moving to the bad exhibit. So when white is bad, is really bad. So imagine a white bad thing in the brain. There are many things. The list is really long. You have enlarged ventricles that will appear white. You have enlarged CSF spaces that will appear white. Edema, exudate, extracellular matrix, and tumors. The myelination and degenerations, all these stuff appear white on T2. So what about T1? Fat-containing lesions will be white. Hemorrhage, subacute will be white, and melanin also will be white on T1. So let's see the first case. There's an arachnoid cyst in the CP angle cistern, fluid-filled space in the CP angle arachnoid cyst straightforward. In the CP angle, we use the mnemonic SAME. It's very helpful because we have 4 lesions very common in this location. 2 of them are solid, schwannoma, meningioma, and the other 2 are cystic, arachnoid, and epidermoid. So what about this one? It's a bad white thing here because of enlarged ventricles in a case of obstructive hydrocephalus because of posterior fossa tumor, and the tumor is kind of white also in this image. So in these lesions in the posterior fossa, including tumors or even infarction or hemorrhage, it's very critical to evaluate for hydrocephalus because of the mass effect induced by the lesion on the fourth ventricle and the adjacent aqueductus sylvius in a confined space of the posterior fossa compartment. I'm showing you another case with IIH where the patient has enlarged CSF spaces. You can see Meckel's caves on both sides, prominent, dilated, and sometimes we describe this as Meckel's cave meningoceles, and you see the prominent perioptic fluid around the optic nerves on both sides. In IIH, there's large CSF spaces, which also will include partial empty cella and calvarial arachnoid pits. You can see here the calvarial arachnoid pits all around here because of the high pressure pulsating against the inner surface of the skull bone. You can see it in this image. These are called calvarial pits. Let's see another entity. Again, there's a bad white thing here, hyperintensity that takes the form of a gyriform configuration here on flare. The rest of normal white thing is actually saturated because it's flare. And you can see the same thing in diffusion in a patient with encephalitis. This could be an infarction, by the way. So SWI is really helpful. And you still can see a very subtle white thing here on the left occipital lobe compared to the right one, which has normal cortical veins. So this appearance is characteristic, and it helps you differentiate encephalitis without prominent cortical veins and infarction that has prominent cortical veins due to sluggish blood flow. A classic example of abnormal white thing is this guy here, located in the left operculum of the frontal lobe here, and you can see it on the flare as well. And you can see also the cortical involvement and expansion. This is very characteristic because cortical involvement is a characteristic feature of oligodendrogliomas compared to astrocytomas, which are usually deeply located without involvement of the cortex. Another subtle example here, you can see a space-occupying lesion in the left mesial temporal lobe. This is a ganglioma compared to the right side. Again, it's white and it's bad. It's a ganglioma, but it's a WHO1 tumor, and it's frequently encountered in cases with temporal lobe epilepsy, as you know. Keep in mind that half of these lesions are solid and the other half is cystic with intramural nodule. A classic example of infarction of the posterolateral medulla, recent infarct. And you can see a bad white thing on FLAIR and a bad white thing on DWI, and the culprit is also white here, the right vertebral artery involved with the thrombus, and you can also see it here. So the tiny white light bulb here ruins the black beauty of the image, as you can see. So it's very important in these cases while you have a tiny infarct to do the DWI, because these lesions can be easily overlooked on T2 or FLAIR. So always do DWI to make a diagnosis of recent infarcts, especially with small lesions. I'm showing you another example of a Wernicke's encephalopathy here in this case, where you can see the perfect symmetry of a bad white thing. So it's beautiful because of perfect symmetry, but it's a bad white thing. It's cytotoxic edema and toxic demyelination by vitamin B1 deficiency. You see involvement of bilateral mammillary bodies, involvement of quadrigeminal gray, and involvement of the around third ventricles, and also bilateral medial thalamic involvement. When you get this, we don't have a wide differential. Differential is limited with bilateral medial thalamic involvement that includes Wernicke's encephalopathy, venous infarction, and also infarct of the artery of Percheron. So again, a bad white thing. So this case is actually uncommon, but I'm going to show you because you can miss it very easy. This is actually abnormal hyperintensity in bilateral dentate in a patient with metronidazole-induced encephalopathy. And you can also confirm the finding after you discontinue metronidazole in the same patient, and you see everything returns back to normal. So involvement of the dentate is characteristic, and the easy way to remember that is the letter D, because metronidazole is usually used for patients with diarrhea. So D diarrhea, D dentate. Let's go to T1. T1, you have this bad guy here. Again, it's white. What could it be? Subacute hemorrhage. So hemorrhage, intracerebral hematoma in a T1 scan, only subacute hemorrhage because of methemoglobin. Remember that, because acute blood is T1 isointense, and chronic blood is dark in both T1 and T2. Another example of a bad white thing on T1 is fat. Look at the scalp fat. So this lesion that is bright in the brain here on T1 is also fat around the corpus callosum. So it's pericallosal lipoma. We have two variants. This is the best one. This is the better one, the curvilinear variant, because it's always thin and it has mild association with mild anomalies compared to the other variant, which we call tubulonodular variant, that is thick, anterior, and usually associated with severe anomalies. So this is the curvilinear variant of pericallosal lipoma. Now we've finished, we've done with the white gallery. Now we're moving to the black gallery. And also we have two exhibits here, a good black exhibit and a bad black exhibit. So here's the black, when black is good. And let's think about what could be a normal or good black thing in an MRI of the brain. So first thing is arterial flow void. So remember this, flow voids, whether arterial or venous, will be black on MR T2 or T1. And then look at air in the sinonasal cavities and mastoids. Yeah, we're dealing with the brain, but we're still in the intracranial cavity, so cranial structures are important to evaluate. And finally, CSF flow sometimes is very useful to see as black, which is good in some cases, as we'll see shortly. We have the first case here with a patient who has absent normal flow void. So this is a good black thing, a normal flow void of cavernous carotid in the left cavernous sinus, while it's gone on the right side, but this invasive cavernous sinus pathology, thrombosis, septic thrombosis actually in this case. And the right cavernous carotid also is not seen in this side. So the black part is the good part. And this is the normal case for comparison. You see here bilateral cavernous carotid flow voids, and also you see the basilar artery flow void in the prepontine cistern. So black is good, and you lose it here. The flow voids are best seen on spin echo. So remember this, because sometimes we do gradient echo for T1. We do it routinely in our practice. So make sure that you're not seeing a gradient echo, because arteries will be bright on gradient echo, not causing a flow void. Another example is air. So we have here normal black thing, a good black thing and a mastoid on the left side and Petrus apex, while you have losted on the right side because of mastoiditis Petrus apicitis, and we give contrast and we see this extensive enhancement in this patient who has Petrus apicitis. You remember that these patients usually manifest with Gradinego triad, where they have the 3Ds ear discharge because of mastoiditis, diplopia because of abducent nerve palsy here, Dorello canal, and deep orbital pain because of trigeminal nerve irritation. Another example of loss of normal flow void. This is the normal flow void on the left transverse sinus, and you lose it here on the right side because of this guy, thrombus on the right transverse sinus, apparently because of mastoiditis. Again, loss of air here on this side. And remember that in coalescent mastoiditis, always do CT, because erosion of sigmoid plate on CT is a red flag for potential spread of infection. Now we're moving to another section, another exhibit when black is bad. So there are some scenarios that a black structure on a brain MRI is really bad, and I'm going to show you a list of things. So first of all, hemorrhage. So hemorrhage is very important on gradient echo SWI. So hemorrhage on gradient echo T2 star imaging SWI will be black all the time. Hemosiderin is the chronic form of hemorrhage. It will be also black, but in T1 and T2. Any case of abnormal iron deposition will see black structure on T1, T2, and GRE. And of course, any high flow voids or dilated serpiginous abnormal flow voids will give you again a black bad thing. Here's an example of hemorrhagic melanoma metastasis to the brain. On GRE, see how hemorrhage appears black and is very characteristic. Now black is bad, it's really bad. Remember that hemorrhagic metastases include melanoma, renal cell carcinoma, choreo, and thyroid cancer. And by default, it includes lung and breast cancers because of the high frequency of these tumors. Another example of a bad black thing is this perfect outlining of the brain in a patient with superficial PL cirrhosis. You see the PL outlining with a black, let me say, pencil-like outlining of the brain stem, and also with cerebellar folia. You have this on T2, GRE, and have it at different sections here. So in PL cirrhosis, most common symptom for these patients is sensory neural hearing loss, probably because of the long course of cochlear nerve. So remember, S cirrhosis, S sensory neural hearing loss. Now I'm going to show you another case of abnormal iron deposition, and you might be familiar with this sign. We call the swallowtail sign in Parkinsonism. This is high field strength SWI, where you can see the split of the posterior part of the substantia nigra here posteriorly, with this core of nigrosome 1 that appears bright. And this is the normal case. It looks like a split of this tail of the swallow. And you can see here in Parkinsonism disease, you can see the abnormal deposition of iron in the posterior part and loss of this normal sign. The sign has a very high negative predictive value. So if you can see the split bilaterally, it's 100% not Parkinson's disease. A good classic example of a bad stuff in the brain is microbleeds. So cerebral microbleeds, whether due to hypertensive arteriopathy in this case, or due to amyloid angiopathy in the other patient, is very characteristic, and you can rely on this on gradient echo. But distribution actually matters, because in hypertensive arteriopathy, there is involvement mainly of basal ganglia, thalamus, and brain stem, while in amyloid angiopathy, involvement is mainly lower cortical and subcortical, as you see in this case. And this is my example of a serpiginous flow voids here, dilated prominent flow void in a case of AVM. Remember that most cases of AVM are solitary. So if you find multiple AVMs at different parts of the brain, always think of a syndromic association. Now, I just came across this idea that we might also find black and white things together in the same image, and which are good. So as good as this panda. So how could it be? That can occur with bidirectionality of flow at the foramen magnum, and other also maybe at third ventriculostomy in cases where we're allowed to evaluate the flow at these parts. So I'm going to show you an example of a foramen magnum obstruction in a case of chiari malformation. I'll show you exactly, when you do CSF flowmetry study, it's very important to see the two colors. So this is a time course series of images. You can see here the craniocaudal flow appears as white, and then when you move through during the cardiac cycle to the rest of the images, you see the other color is black, which represents caudocranial flow. This is very important. We do this with our cases to make sure that we have bidirectionality of flow, and you can see the screenshots here of both colors and the time course of the velocity spectrum above and below the line, representing bidirectionality of flow, which is really important to identify whether there's functional obstruction or not, and select your patients who will benefit from surgery for chiari malformation 1. Now, let me think about a black-white combination that is bad in our tour. So there are many scenarios, and this scenario is actually is really bad. So I'm trying to remember that racial segregation between white and black people. And you'll see that in neuroimaging, we also have bad scenarios, very bad scenarios for white-black combinations together. One of them is diffusion restriction. So when we see sets of images of DWI and ADC, DWI bright and ADC dark, here's the black-white combination, and it's really bad. Other examples include the black rim and cavernoma. Cavernoma is white, but the black rim around it will help make the diagnosis. Lipoma is white, but the black cap above it will help make the diagnosis. And we'll see that in a minute. And the central vein sign in MS, think about MS SWI, you have SWI, you see an MS plaque, and you see the central vein sign as a black linear structure passing in the center of the plaque. Again, this is a black-white combination. And finally, aneurysms sometimes do the same thing. The classic case of diffusion restriction in a patient with recent infarction. Bright DWI, dark ADC. This is very classic. This is very basic. Just to see how clear is this combination of white-black thing. That means that there is recent infarction. Remember that ADC will normalize after 1 week, meaning that when you see this combination, that will help you identify the age of the infarct. So know that this infarct is only 1 week old. Another example, but with another flavor, is diffusion restriction, but with abscess this time. So abscess is well known to do diffusion restriction. You have ring enhancing lesion here. You have, again, white and you have black. White on diffusion, black on ADC. But what's that? This is pus in the ventricle, so don't miss it. Again, same combination of white-black thing. And the more subtle thing is the ependymal lining. And in this case, the patient has ventriculitis. You can't miss something like that. You have the ependymal lining here, which is bright, white, and you have it here on ADC, which is black. And this combination, again, is characteristic for ependymitis or ventriculitis, which sometimes is present even before formation of pus. Another example of a bad white-black thing is the epidermoid cyst. You have it here, white on DWI, black on ADC, and the CP angle. And I mentioned before that CP angle cysts are either arachnoid cyst, which does not restrict diffusion, or epidermoid, which does restrict diffusion, as you can see in this case. Here's an example of a central vein sign on SWI, and this is the zoomed image. You can see it here, the plaque on SWI, and you have the vein inside the plaque. So this is central vein sign. Everybody's talking about it, and it's very well correlated with multiple sclerosis compared to other forms of demyelinations. But to be considered as a positive central vein sign, there are some criteria, including that the vein, the fact that the vein must be visualized in 2 different planes, at least 2 perpendicular planes, and be positioned in the center of the lesion to be considered as positive sign. Another example of cavernoma here. The cavernoma is classic inside. It's white because it has some blood, but subacute or maybe early chronic blood. And then you have the dark rim around it, which is hemosiderin. So hemosiderin is due to chronic blood around the lesion, and this is very characteristic to make a diagnosis of cavernoma, which we call it popcorn lesion. Actually, the best analogy is to call it chocolate-coated popcorn lesion because of the dark rim. Remember that we have 4 types of cavernomas according to Zabramsky. Most common type is type 2, that we see here in this picture. Example of lipoma, how can this be black-white together? This is really helpful because you see the lipoma is white on T1. We mentioned that before. But if you look carefully, you see this cap above at the top of the image here, the cap of black rim here. And again, you can see it here. This is called chemical shift artifact. It's because of misregistration of the lesion itself. Although it's an artifact, but it's really helpful to make the diagnosis of a lipoma or fat-containing lesion. And it happens along this direction, which we call it frequency encoding direction, because the other direction in the standard MR system is called phase encoding direction. And this is my last example with the black-white thing together. Giant aneurysm, and we can see swirl of the flow in the giant aneurysm here. And that's why you can get some sort of black-white combination. Sometimes aneurysms partially thrombose from inside. So it will give you, again, a combination of color. And a giant aneurysm, which is the one that measures more than 2.5 centimeter in the greatest diameter. So now we're done with the gray, with the black, white. So this is the gray, these are the gray shades. Now we're moving to the color section. So here's the color section. Welcome to the color part of my of the tour. And color is really important in neuroimaging. It's a way to express yourself. It's a way to interpret data and to interpret findings in a good way. Actually, you see how this is possible in neuroimaging to interpret your findings or to deliver your message to the reader, to the physician, by the use of color. And I'm going to show you a couple of examples, including MR spectroscopy, MR perfusion, and I'll show you also bold fMRI, how we display color fused on brain anatomical images to show you cortical activation. And finally, we'll end the talk with DTI, and we'll see how coding the tract will help identify tract integrity and also orientation of the white matter tract using DTI in the brain. So here's my first example with MRS showing choline NA ratio in a patient with high-grade glioma. And you can see here the choline is very high compared to NAA, and you have here the color map of choline NA ratio, with the center that is actually red in the center of the lesion. And that helps you identify the pathology of a high-grade lesion and help also guide the biopsy in these tumors. In MRS, remember that choline is a marker for cellular proliferation, while NAA is a marker for neuronal integrity. So C, cellular proliferation, and neuronal integrity, and that explains why the ratio is high in a high-grade neoplasm. Another example of a color map that shows you the distribution of myoinositol in a patient with gliomatosis cerebri. Myoinositol is really important to make the diagnosis because it's a marker of gliosis, and at the same time, it will guide biopsy from the correct part of the lesion because of high concentration here. So let's see how color is really important in our practice. Let's move to perfusion, and this is DSC perfusion, dynamic susceptibility contrast perfusion color map using RCBV as the metric. CBV is cerebral blood volume, and this is best used and applicable in neuro-oncology. You can see this GBM, and you can see how the CBV is very high in the GBM, helping you to make the diagnosis and grade the lesion. So this is the most common technique that we use for MR perfusion. And remember that RCBV is the main metric that we use with tumor imaging, perfusion tumor imaging, using this technique. Compare this to another case of a low-grade tumor, ganglioma, and you can see here the RCBV is very low in this location, and compared to the other side. Always we used to compare the same spot on the other contralateral normal hemisphere. Here's an example of an abscess, and I'm showing you this to see that the perfusion is actually low. It's very low on abscess, regardless of the enhancement pattern of the abscess, because DSC perfusion estimates microvascular density, and this parameter is actually increased with neoplasms, with neoangiogenesis, with new blood vessel formation, something that we don't see with inflammation. That's why it's really important to do for differentiation. And this is another example of a patient with recurrent GBM, while another patient with radiation necrosis. And you can see here flare, abnormal enhancement, and abnormal RCBV here that is displayed in color as red spot. Compare this to the other case with radiation necrosis. You have normal enhancement, but you have nothing here on perfusion, meaning that the patient has radiation necrosis. So in radiation necrosis can be very similar, and you need to do this perfusion technique. It's mandatory to make this differentiation. Another example of perfusion is ASL, another technique that we use, and it's called arterial spin labeling in a patient who had GBM here with high perfusion displayed by color. And you can see here compared to this patient with tumefactive lesion who has actually very low perfusion, so you can make differentiation very easily in these cases. The best thing about ASL is that it's the only MR perfusion technique that does not require contrast administration, and estimates CBF. I think I have only 2 minutes, maybe less. I'll try to finish before that. Here's bold fMRI when we have a patient who actually came with seizures, some sort of left hand twitches because of this low grade lesion. And when you did hand motor task activation, and we fused the bold fMRI images of the color on the anatomical images, you can see how the lesion is very close, very adjacent to the hand motor or the cortical motor area here. That explains why the patient has hand twitches, and also provides a roadmap for epileptologists and neurosurgeons if they want to intervene in these lesions. So it's a blood oxygen level dependent sequence that we acquire during performing a specific task to localize cortical activation, and then fuse the color on the anatomy of the images. Another example of a patient who is left-handed and has a right astrocytoma, and before resection of these tumors, we always need to lateralize the speech area. Here's Broca's. here's vernices, and now we're sure that the resection of this tumor is going to be safe in terms of speech preservation. So preoperatively, evaluation of these lesions is actually will complement or replace the awake craniotomy for in these patients. So my last two slides will be on DTI. Again, this is a very nice, beautiful, fancy, colorful image of FA. What's FA? It's the fractional anisotropy map that we do to tell us some information about white matter tracts. We have 3 spectrum of color. As you can see, the green spectrum codes those association fibers, while the blue spectrum, as you can see here, the corticospinal tract, codes the projection fibers coming from the brain to the spinal cord, and the red spectrum actually codes the commissural fibers or crossing fibers from both sides of the brain. And can quantify the FA value as well. It lies in the range from 0 to 1, with the higher range meaning that the tract is intact, while the lower values mean that the tract is infiltrated, edematous, or pathological due to any etiology. My last slide is this case that we've seen recently in a patient who has primary lateral sclerosis. You can see a very subtle atrophy in the right motor cortex, I mean, with some sort of very subtle signal, and prominence of the central sulcus in this region compared to the other side. You'll see the difference. But when we did tractography and we did DTI to this patient, you can see the difference in the corticospinal tract on both sides. With this one, the normal one, blue color coded, and the right one is shifted to the purple color just because loss of intensity of the color and loss of integrity of FA values of this tract. Remember, this is some sort of tractography. It's a tractopathy, motor neuronopathy again. So it was very helpful, and I'm going to show. I'm happy to show you how color is really important in these cases. Gives you extra fine information. You have the partial loss of fiber tracts via the corticospinal tract compared to the other side. So again, the normal corticospinal tract is coded in the blue spectrum because it's a projection fiber compared to association fibers between cortex, which are coded in green, and commissural fibers or crossing fibers, which are coded in red. See how color is important. Okay, so welcome back. I'm sorry, I know I took extra minutes. So welcome back to from the tour. I hope you enjoyed it. We've seen some white structures, black stuff, both good and bad. And we had a stop in the color section of the gallery to see how color is meaningful to us and also to you. Thank you for listening and for paying attention.
And thank you for the great images and tour. Questions will be kept to the end of the session.